morning, everyone. Just to confirm, I have no conflicts of interest, and I have got some patient case studies within the presentation. I have consent from all of the patients to share this information. So, sorry. The aims are for us to explore the role of fear as a biopsychosocial factor in pain and injury, for us to understand where this fear comes from, and to identify how we can address the fear. There's one thing that I hope that you'd all take away from today, and that's, as healthcare professionals, we all have a role to play in reducing fear. So, I used to have a big fear of giving presentations. My hands would get sweaty, my heart would be beating fast, and if I could remember the words, I would struggle to say them. So this conscious feeling of fear, this is what we're talking about today. But it's important for us to understand that there is a non-conscious side of fear. There's some threat-related processes which indirectly will lead to this conscious feeling. So we all know that the conscious feeling it varies between people, it's subjective in nature, and the experiencer will use different words, different language to describe that experience. It's a bit like, if you've ever asked a patient, have you got pain? And they say, no, but it hurts. Or you say to them, well, does it hurt? And they say, well, no, but it's a bit sore. So language is really interesting. It's a really great way for us to show the difference, the subjective nature between these experiences. In the English language, we have about 40 different words that can describe pain-related and fear-related emotions and feelings. So another fear that I used to have was of those yellow flag patients. Now, I was warned about them at university. The patients that physio couldn't help, the ones that it was just beyond our scope. And it was quite demoralising then as a new graduate physio to start working and realise actually there's yellow flag patients everywhere. And I didn't sign up for that. I wanted to be able to help people and to realise that this group of people that I felt like I just couldn't help. But it was okay. I had a solution. I was going to work in elite sport. That was my aim. And surely that's a safe zone. But unfortunately, of course, athletes are human beings too. And there's yellow flags in sport. So I realised in order to be a good physio, I just had to embrace these yellow flags. I had to start to look through a broader lens to really understand the whole person and how that relates to the presentation in front of us. And actually working in elite sport was a really good way for me to embrace and to understand the biopsychosocial model. In performance, it's quite obvious that you can't separate the mind and the body. So I was able to develop an understanding that worked for me, which showed that actually there's a dynamic contribution of the peripheral and the central components, and this varies depending on the person and depending on the context. We now have some good literature which shows the importance of biopsychosocial factors in injury risk, in pain management, in rehab outcomes, and particularly return to play. A key message from the 2016 consensus statement was that we need to consider psychological factors during the rehab and at that transition back to sport, and that this relationship can vary. Psychological factors were identified as a much needed area for further investigation and research, and that was alongside the biomedical, alongside performance areas. So fear is a biopsychosocial factor that's mentioned a lot within the literature, and that fear can be of the pain itself, it can be of re-injury, it can be of movement, and the fear of re-injury and movement might not necessarily be alongside a fear of pain. This fear has impacts. It causes psychological, behavioural, physiological changes. And those changes, apart from maybe in that very acute stage of injury where the fears may be part of the need to protect. And fear is, within human evolution, It's an important response for us to have. But in rehab, once you get past that acute stage, I've not read any literature that says that fear is a good thing. It shows that it can slow the rehab process, it can delay that return to sport, and actually it can have an impact on the level of sport that the person returns to following injury. I don't know whether you're aware of Derek Rose's story. So he was heavily criticised in the media, because once he was cleared by the docs to say he could go back and play, he just said he wasn't ready. And the media's reaction to that, well, he should be going back. So it's a good example of how we need to consider the readiness for return to sport when we're making our decisions around return to play. Now, Derek Rose went on to have more injuries in his career, and he's been criticised again more recently because he's decided he might not do as much on the court. He's reduced his court time. And his reasoning for this would be to reduce the impact of pain and suffering once he's finished his playing career. Now, this could be described as avoidant behaviour. An avoidant behaviour, it's a common behaviour that's associated with fear. So I don't know whether, but I'm guessing many of you have chosen to not participate in your sport that you did when you were younger, maybe a contact sport. As we've got older, as we've got a bit more responsibility, and we decide that the risks of injury are just a bit too much, maybe it would impact our employability or our ability to earn income. So that's relevant to all of us. So avoidance can be, it can be a range of behaviours, from just stopping a sport to perhaps just maybe not doing a certain element of training, or maybe just changing a little bit of the movement, like avoiding loading one limb compared to the other. The fear avoidance model has been used to help us understand this, and you can see that there's a cycle where with the avoidant behaviour then can cause physical deconditioning and disability. Not everyone avoids in response to pain and fear. There is a diverse response, and some people will endure. So some people will push on despite the fear, despite the pain. And I think this was noted with Sean's research around Achilles tendons, the qualitative research, where some people will want to run no matter what the outcome is. Some people would very much just stand back and say, okay, I'm just not going to do it. So when we have this enduring behaviour and people are pushing on despite the fear, what we often see is perhaps what I would call like micro-avoidant behaviour. So they're still pushing, but there's little bits about their movement. They modify their movement to allow them to continue to achieve their goal. So we know that fear can be a prognostic factor. There's a systematic review that was published last year that showed some evidence that the baseline fear avoidance can predict pain and disability at 6 months. And the same systematic review also shows that there's this relationship between the more fear, the more pain, the more disability. And there's some strong evidence for that. The fear avoidance model helps to explain it a bit, but that's much more around that it's disability that drives it, where actually if we go back to the definition of fear, if pain is a perception of threat and the feeling of fear is an evidence of a threat state, you can understand that it's the threat that's perhaps underlying this link, this relationship. So we know that fear is relevant and that we need to consider it. The literature tells us that we have to consider it. But as I was trying to change my way of thinking, change my linear way of thinking, I just kept thinking, well, I'm not a psychologist, so how am I going to do this? And I certainly wasn't alone. The literature shows us that physios are not so confident in applying this biopsychosocial approach. But the more I learned, the more I realised that actually, as a physiotherapist, I had the skills already that I could apply. So surely we can use our keen observational skills to assess fear. So let's have a little look at this example. if we look at this picture here and standing, perhaps it looks like she's offloading her ankle. Perhaps it looks like she doesn't want to weight bear through that leg. And when you look at her in sitting, the lady's actually, her fear was more around offloading her pelvis and not wanting to put the weight through that side. So just by watching, we can get a lot of information. Some more examples. So take the guy on the left. Anyone got any suggestions what he might be fearful of? Any ideas? Exactly. As he's coming to sit down, he's just bracing through his arms, not wanting to flex his trunk. Now actually, if you look at all three, they're all afraid of flexion. Guy in the middle is using his hand to try to give him some support and keeping his back straight. It's not so obvious, but let me just show you the movement. So this guy's working really hard to keep his legs and his arms relaxed, but I don't know whether you can see, he's really still bracing and guarding around his spine, and he's not allowing any relaxation through his spine. So the other thing we can observe are expressions. Quite obvious, isn't it, what expression we've got here? What about this expression? What do you think is going on in his mind? He's really psyching himself up to lift up that big weight. And we see that with sympathetic responses. The description I gave about my fear of giving talks, my palms being sweaty, my heart beating faster. We can observe these in patients. They don't need to necessarily describe them to us. And what about this expression? What's going on here? Could it be pain itself? Could it be fear? Could it be disappointment, like Rod suggested? It gives us a base to ask some questions. Now, the other good skill that we have as healthcare professionals, we're all really good at listening, yeah? So if we start our interview with a really open, reflective question, like tell me your story, and then if we just listen to the language that the patients use. So it can be really obvious, as in Tiger Woods' example, and also this example of someone who had an ACL reconstruction. And it might not be so obvious. This is an example again from Sean O'Cauliffe's work, his qualitative work with tendons. But if we really listen to all those many different words that people can use to describe things, we get a sense of what they're feeling. Of course, we can just ask them. Sometimes people might not want to tell us that they're scared. They might not think that they're scared, despite having these sympathetic responses. We can use a simple Likert scale. The Askeline H test, which is demonstrated so beautifully by Nicole and Hassan here, is in that test, the idea is to ask the person to rate their insecurity on a scale of 0 to 100. And it's been used to help to inform decisions around return to play. And Askeline would suggest that insecurity rating needs to be 0. We could use more formal outcome measures, like the Tampa scale of kinesiophobia, which has been used a lot in literature around many different MSK conditions. Or we could use the FODA. Now, FODA is a series of photographs. They show different activities of daily living, and the person is asked to rate these on how harmful do you think this activity is to your back, on a scale of 0 to 100. And then we can create a hierarchy of feared activities. So let's have a little think. Who thinks number 1 is most harmful? Show of hands if you think number 1 is most harmful. What about number 2? Does anyone think neither of them are harmful? Good. It's my bias coming out there. Okay, so where does this fear come from? We've mentioned the fear avoidance model already. So catastrophizing is key to the fear avoidance model, but it's only focusing on two factors, that the catastrophizing comes from negative effect and threatening illness information. The only problem with that is if we take a truly biopsychosocial approach, we probably need to consider more behavior, the somatic pain experience, and also, it doesn't take into account just the fear of re-injury or enduring behavior like we talked about before. The other limitation around the fear avoidance model is that in order to get recovery, we have to extinguish any catastrophizing. The common sense model is a more broader model. So this is basically including broader sense-making processes where us as human beings, we form a construct. We'll ask ourselves these questions in response to an injury or to pain. Now, if you think, these are questions that athletes and patients often ask us, aren't they? So they're trying to get information from us to help to influence the construct that they have. In response to that, we sort of take a problem-solving approach, and if our progress is heading towards our valued goals, then the construct is supported. If it's not, if we're not improving as we would expect, then we have to reevaluate the construct. And we'll ask more questions, and we'll keep on asking the questions. So, does Pavlov and his dog ring any bells to anyone? So, we have this idea that fear is learned. And I don't know whether anyone else remembers Derek Redmond he was a 400 meter sprinter for the British team. In the 92 semi-final, he sustained a hamstring injury. There's a 12-year-old girl watching this on the telly. It was extremely emotional, watching as his father comes and helps him over the finishing line. So injury can be very distressing, especially when the consequences are significant. And, not just with athletes, but with all of our patients. And people really don't want to go through those consequences again. So it's not surprising that fear is a strong factor. We can also learn this fear just from observing others, whether that be a teammate have an injury, and particularly a bad injury, or whether just we're watching family members suffering with back pain. Now, family members and friends are often, I find with my patients, they're often very keen, and some healthcare professionals as well, very keen to describe to people how horrifying their injury was, or how, disastrous it was. And the language that can be used with that is creates a very strong impression of fear. And it's a well-meaning, discussion. They also, I don't know about you guys, but my patients are often getting WhatsApp messages with friends and family sharing internet resources or links to different products that might help them. And the problem is we don't have any quality control over these products. And the messages are sometimes in the media and delivered by the companies behind the products who have a vested interest in us thinking that pain is equal to damage and us thinking that the body is vulnerable. So this also can add to the fear. So just a couple of examples. These really dangerous smartphones that we have. And this one, apparently sitting relaxed with your feet up is the same as being poisoned. And even the MPs are at it, even the politicians are at it. So this is from a British member of parliament who is calling to ban low-level letterboxes. Now, I can understand the risk of being bitten by a dog, but for reducing back strains? Now, unfortunately, we all have a role to play in this as well. So in giving our well-intentioned, well-meaning advice and explanations, we have to realize that we can also contribute to the fear. So, say for example, if we're describing to someone that their tendon is painful because it's swollen and it's inflamed and it's degenerative, and we say that really they mustn't run. But then in the next stage of their rehab, we're getting them to do painful exercises. It'd be pretty confusing for a patient, and this certainly, I think, came out in Sean's research. But also, what about if we're telling someone that they have an injury that won't heal, ever? What are they going to do with that information? Especially if we're talking about injuries like tears that are there in asymptomatic populations, like meniscal tears or annular tears, or we're using the word injury to describe degenerative changes. I'm going to give an example of core stability, of how this can have a big impact. So core stability is an intervention that's recommended by many healthcare professionals for a myriad of complaints. But this is an intervention that is not supported by any good evidence, and we certainly know it's no better than any other type of exercise. Now, often the justification for core stability is around someone being unstable, in that we're telling them that things are out of place, or that when they're moving, we can see this instability. Now, from some qualitative research, we know that when people hear the word instability, they may think that it means that something's about to pop out at any time. The instructions when we're doing core stability exercises are a lot around bracing, particularly the transverse abdominis muscles, keeping that neutral spine. Now, this implies, 1, that there is a core, 2, that it's safer to be stiff, 3, that we must pre-tense before we do any movement, and in order to be safe, that we must keep this neutral spine. What we know is, particularly in lower back pain, that people with pain, they tend to already move more stiff. Jeremy Lewis mentioned this last week in his lecture, that there's less variability, that there is more muscle activity. Now, we know that tensing can be provocative. Kieran, I think in his first lecture, Tuesday lecture, he gave an example of a wrist movement. I don't know, should we just remind ourselves? So I want you to all make a circle with your wrist, okay? Feels fine, no problem. Now clench your fist as tight as you possibly can, and now try doing the same movement. Feels a bit clicky, a bit clunky. And what if you kept doing it? Get a bit sore? So if we've got patients who are already moving stiff and guarded, and then we ask them to move like this, are we helping? This can increase the compressive forces, and actually some people find that they have then more pain. And the literature shows us, it backs up this idea that our beliefs and our fears certainly influence what's happening with the patient and their experience of the rehab process. So I've got another example from a patient of mine who of how things can go wrong. So here is his words. He describes what he was like before a particular event and afterwards, and this event he describes as particularly frightening. So have a little look at the differences. Okay, and so for those who haven't seen this before, a certain event happened on the 16th of May, a day that the patient describes as being among one of the worst days ever. Any guesses around what happened? On the 16th of May, this happened. So he remembers feeling petrified from getting those MRI results. His MRI results showed a broad-based disc bulge at L4, L5. And when he went to see the surgeon, after seeing the doctor in the emergency, clinically there was no sign of nerve root compression, and surgery was not indicated. But you can see from the patient's words here, that was not his understanding. He thought this was something that he was going to have to be careful of for the rest of his life. So we've understood that fear is important, it's relevant. That fear is a common sense response to a variety of threatening information. And unfortunately, that includes our well-intentioned advice and explanations. But then what do we do about this fear? I'm still thinking I'm not a psychologist. So should we send everyone to the psychologists? And we've got some great psychologists here who I'm sure would be very happy to support us, but perhaps they'd get a bit overwhelmed by numbers. But still, we don't need to be. Remember, every contact we have with a patient or an athlete, it is a psychological interaction. The tricky bit is just getting that psychological interaction right. In order to do that, a biopsychosocial approach will help. But before we think too much about the psychological and social factors, we've got to get the bio bit right. What's the main reason that people come to us? Pain with injury. And when I realized that actually my knowledge of pain from my physio course was perhaps out of date, a little bit lacking, then I realized I needed to learn more. I needed to update my knowledge of contemporary pain science and of biology. And when you do that, then the psychosocial factors fall into place. So we've got to get the bio bit right first. We've also just got to acknowledge what our fears and our beliefs are. And if we think back to the photo images, what information did we use to decide whether something was harmful? Was it based on the most recent evidence? Or is it linked in with societal beliefs? So rehab that's embedded in a biopsychosocial approach can certainly help us to reduce fear. And exposure, which is a commonly used approach to reduce fear, that can have some similarities with rehab. So surely a graded rehab program is very similar to a graded exposure program. But then why do athletes who have gone through a progressive rehab program and been successful at all the physical kind of benchmarks, why do they still have fear? And it's actually looking at the differences between rehab and the differences between exposure that helps us to understand this. Exposure can be applied in a few different ways. It can be indirect or direct, and we can do this really graded, hierarchical approach based on, for example, the photo images. Or we can throw them in at the deep end in a full throttle approach. But the idea is that we need to get the person facing their fears repeatedly, and ideally to show them that there's no harm. So if we have a look at this guy, so we discussed earlier on that he was bracing his spine, that he had a fear of bending. Now, an individualized rehab program, we would say that that's a ideal way of working. So then if we individualize our approach to fear, his fear is of bending, so we've got to get him bending. He could have played basketball the way he's moving on the left there, but he still still did have a fear of bending. So unless we targeted the bending, we're likely to get some barriers in his return. Okay, so further on that individualized approach. Let's have a little look at these two pictures. Which one do you think had more pain? The left one or the right one? There's a bit of debate. And the idea is that it needs to be individualized. So for this guy, it's the one on the left. Because this is the one where he's using his protective strategies. He's avoiding the thing he's fearful of, which is flexion. He's bracing and guarding and breath holding. So in an individualized approach, we need to then get him relaxing, encouraging him to flex his spine. And he was able to then do it without pain. So we can look at progressing rehab by getting him to face the things that they're feared of. We can do that in a pain contingent manner. So quite often with rehab, we might progress from one exercise to the other when there's less pain. But for this guy, if we wanted to progress him from picking up 6 kilograms to picking up 8 kilograms, and we waited until he had no pain, we're going to get a bit stuck. So we can use behavioural experiments to modify the pain experience. Now he can pick up 6 kilograms without any pain. So behavioural experiments are a way of modifying the protective strategies. It's a great way of the person learning about what they're doing, what their body's doing in response to fear, and also helps them to challenge their own beliefs. We don't necessarily have to change the pain. This might be a big difference between an exposure progression and a rehab progression, in that if someone has some pain when they're doing an exercise and they're fearful, there's still an idea that there's a mismatch, that pain is usually less than what they expected it to be in the first place. So you can still get some disconfirmation of their expectations, even if the activity is painful. Okay. So for this guy, who also had a fear of bending, we did it in a different position. So he's very fearful of bending and standing. We changed the context. He's able to bend. His slump is positive for pain in his leg, so he's sensitized. He gets no pain at all when he's doing this. So these behavioral experiments and changes of the context that we do the exposure in can make a big difference to the patient's experience, but also in how we can then progress their rehab. We can integrate the exposure into conditioning exercises. So we've got 2 guys here who are fearful of bending. We can modify their rehab exercise where maybe he's trying to condition their abs or get their legs working. And the top example is a sport-specific. He's a volleyball player, so he's pretending he's going to receive a shot. So we can get them to do that with the flexion position. What's really good about integrating it into exposure is that often you'll see the tendencies and the habits that the people have. So that they may be doing everything in a fixed extended position, and we want to change that into a more relaxed flexion position. Context-specific exposure then takes it that one step further. So a great example of doing this well would be within the hamstring protocol. If someone has injured their hamstring while sprinting, and we get them returning to running, and they're a bit fearful at first, but then they build their confidence up. We need to then get them back to sprinting. Because often there's not a generalizability from one context to another. So running in the gym might be fine, but sprinting on the track might elicit completely different emotions. And the same with this bottom example. This is a patient who had an ACL reconstruction, going that one step further, getting back to the place where they had the initial injury and the emotions that brings up. So we should be thinking about in our sport-specific rehab to make the exposure very context-specific. One explanation for the hamstring protocol, where if someone's passed all the benchmarks and they have no pain, but yet they're still reporting some insecurity on the H test. Now, Carl Askling would recommend that you just delay the return to sport and they do more rehab. Now, perhaps this can be explained by it's a repetition of exposure, that we're doing more volume and that we're repeating the feared activity. And then that builds confidence. We also really want people to build their confidence just generally in their day-to-day lives. That if we've helped them through their rehab make sense of their fear, make sense of their pain, that they have started to challenge their own beliefs, they'll hopefully then build some self-confidence and efficacy. Safety behaviours are often really difficult to identify. Now, this is a patient of mine who I hadn't realised for weeks that he'd padded his car out. He was so afraid of sitting and the damage that he could do in sitting. He didn't have pain when he was sitting, but someone had told him that it was bad to sit in a particular way. So he'd padded the car seat so that he had to sit a particular way. And I wasn't aware of this, but as we were progressing through his rehab and he'd started to challenge his own beliefs, he told me about it, and then he sent me this video where he'd independently gone off and he'd changed his own safety behaviour. I think we can apply 3 basic principles to the rehab that we're already doing, to the interactions that we already have with our patients, and we can address fear. We can use our up-to-date knowledge to educate and to de-threaten. We can use exposure to desensitize, and we can also use it within our rehab to build confidence. And of course, this is assuming that we're using a person-centered multidimensional approach. So if we do it well, if we get those basic things right,
they change the way of thinking about your problem and even the way of thinking about your pain.
It can have a big effect. So some take-home messages. Fear of pain and injury is relevant. We do have to address it and the other biopsychosocial factors. We don't have to be psychologists. We can ask the psychologists for support. We have a role. At least let's not make people more scared. And at best, maybe we can try to reduce the fear. Some simple principles can hopefully make a big difference. Thank you very much.